Clinical examination of the central nervous system. Gait. So if the patient is able to stand, get him to stand and take a few steps and observe the gait. So note the presence of scissors gait in spastic paralysis, and observe hemiplegic gait where the upper limb is flexed and adducted across the chest, and the lower limb makes a semicircular sweep as a conduction when walking. So note the shuffling gait of Parkinsonism with failure to swing the arms when walking. So look for a tragic gait of a patient with hip pain, and observe the high stepping gait in patients with foot drop. The abnormal gait can either be painful or painless. In painful gait, the body takes weight of the painful limb as much as possible. So is the rhythm which is disturbed. So less time is spent bearing weight on the affected limb, and more time is spent bearing weight on the normal limb. In a painless gait, the contour is abnormal, and this may be due to 6 conditions. It could be osteogenic, atherogenic, myogenic, neurogenic, psychogenic, and prosthetic. So osteogenic will be due to shortening and deformity of bone. Atherogenic due to deformity, laxity, or stiffness of gait. Myogenic, that's due to weakness of muscles. Neurogenic due to organic disorders of the nervous system. Psychogenic as bizarre gait resulting from psychiatric causes. And prosthetic due to wearing of an artificial limb. In hemiparesis, the affected limb is usually held flexed at the elbow and adducted across the chest, while the leg on the same side is stiff and swings forward in a semicircular fashion rather than being lifted from the ground. In paretic patients, that is patients with upper motor neuron lesions of both legs, this is a slow, stiff movement of each leg in turn, with the feet remaining in contact with the ground. So in severe cases, the patient assumes a scissors gait. In foot drop, the patient tends to lift the foot high to clear the toes from the ground, and as it is retained, there is often a loud slapping noise, and the lesion is readily detected by the ear as well as the eye. Unilateral foot drop may be due to compression of the common peroneal nerve or to a prolapsed intervertebral disc. A high stepping gait affects both legs and is found in bilateral foot drop, and is caused by a generalized polyneuropathy, loss of postural sensation in the feet in tabes dorsalis, and this also produces a high stepping gait. Instability of the knee joint or wasting and weakness of the muscles of the knee joints leads to hypotonia, which makes the patient fling the leg forward in a flare-like manner as he walks, and this is seen in poliomyelitis. A waddling gait is also seen in congenital dislocation of the hip, wasting of gluteal muscles in primary disease of muscle myopathies, and occasionally in lesions of the anterior horn cells. In cerebellar lesion, the patient walks unsteadily with a wide base or in a drunken reeling manner. The lesion is confined to only one posterior lobe of the cerebellum. The patient staggers or drifts to affected side on walking, and this becomes more obvious as it turns. The lesion of the nerves causes a jerky rocking of the trunk from side to side, similar to a man walking on a tightrope. In Parkinsonism, the gait is slow and shuffling, each step being smaller than normal with an absence of arm swinging during walking. Some take increasingly rapid small steps forward in an attempt to maintain an upright posture, and this is known as Festinant gait. In a tragic gait, the patient is unable to bear weight on the affected limb, and the patient spends less time on the affected limb and more time on the normal limb. So just a recap. So we have Caesar's gait, hemiplegic gait, Festinant gait in Parkinsonism, atragic gait, and high stepping gait as foot drop.